Diabetic nephropathy, I think, is a commonest nephropathy nowadays. And this is arbitrarily defined as persistent albuminuria, more than 300 milligram, that is confirmed by at least 2 occasions in 3 to 6 months. Because sometimes proteinuria is very common if the patient is having some fever, infection, or maybe due to drugs, maybe many reasons there may be a transient proteinuria. So that is why at least you should confirm it by 2 occasions within 3 to 6 months. And also it includes progressive decline in the glomerular filtration rate. So once below 60 ml per minute, so the definition of diabetic kidney disease includes both persistent albuminuria and decreased GFR. And another very important thing, it is that you have to exclude other causes of kidney disease, because the diabetes patient may have other kidney diseases other than diabetes itself. So 40 to 45% diabetes will develop DKD, and 40% diabetics will have non-diabetic kidney disease. And now it has become the #1 cause of kidney disease worldwide. And more than 50% patients on dialysis are diabetic. So what are the pointers towards non-diabetic kidney disease? Because this is very, very important as far as kidney disease in diabetic patient, because the management is very different if the patient is having diabetic kidney disease and non-diabetic kidney disease. And as I have mentioned, that 40% of all diabetic patients will have non-diabetic kidney disease. So what are the pointers? So absence of retinopathy. So retinopathy, usually, particularly type 2 diabetes, there may not be any correlation in maybe 5 to 10% cases, but most of the cases it is present. And 100% of type 1 diabetes, if there is no retinopathy, that means you can conclude that the patient may have non-diabetic kidney disease. And rapidly decline in GFR. So what happens in diabetic kidney disease, GFR falls very slowly. And if a patient is having refractory hypertension, so refractory hypertension say that indicate that patient may have some other causes of hypertension, not due to diabetic kidney disease. And active urinary sediment. So what is the active urinary sediment? If the urine contains hematuria, blood class, any cast, so that indicate that patient may have some glomerular disease other than diabetes. So an active urinary sediment, sign and symptoms of other systemic disease, like the patient has some autoimmune disease like SLE or rheumatoid arthritis or anything. So if patient is associated with some other systemic disease, then may not be this kidney disease, may be due to other causes. And greater than 30% decline in GFR, then the baseline after starting AC inhibitor or ARB. So that indicate there may be associated renal attrition also. So these are the very few important things before you proceed for management of diabetic retinopathy. Very important to exclude non-diabetic kidney disease in diabetic patient. So I think everyone knows this. What are the factors, risk factors: age, sex, race, ethnicity, family history. So these are the non-modifiable factors. And definitely the initiating factors, most of the time it is the hyperglycemia and acute kidney injury due to anything, maybe drugs, maybe infection or whatever maybe. And progression factors are hypertension, dietary factors, obesity, that I will discuss later on. So the pathogenesis includes both metabolic and hemodynamic factors. So that production of glycosaminide and this advanced glycation end products and this hemodynamic changes, production of cytokines, chemokines that lead to kidney disease. So this is a very important slide. Actually, the present management of diabetic kidney disease based on these three factors. This is inflammation. Actually, I have already mentioned that there is a lot of production of cytokines, chemokines in the kidney that lead to inflammation. And you have to manage this inflammation, and this is very important as management also. And different drugs are used for this inflammatory to reduce the inflammation. Hyperglycemia, I think everybody now, last 2 days, it is discussed how to control hyperglycemia, which is a major factor for DKD, and hemodynamic dysregulation. So if you'll see the progression of kidney disease, actually three types of your progression of kidney disease occurs. The major one is where the patient from, they start from non-albuminuria to macroalbuminuria, then they go to the macroalbuminuria, and there is this is the classical DKD, and there is a sudden fall actually. After they develop this macroalbuminuria, there is a sudden fall of your kidney from GFR, and they go to kidney failure. But if you see, if you properly manage these normal stages or microalbuminuria stages, around 25% there will be regression of albuminuria. So this is the golden period. The non-albuminuria state or microalbuminuria stage, this is the golden period as far as the management of DKD is concerned. Unfortunately, by the time they come to the nephrologist, there is nothing to be done by the nephrologist. So this is the part where the physicians who see the patient early stages, this is the golden period, the stage of microalbuminuria and the stage of your normal albuminuria. So this is the stage where if you manage properly, then there will be then there is your reversal of your albuminuric state. And another group of patients, there is a steady decline in the kidney function. Whatever you do, they gradually there is a rapid decline. They are known as rapid decliner. Whatever you do, they reduce their kidney function, reduce tangentially. And there is another group, they never develop proteinuria, they are never proteinuric or non-albuminuric, and they go to the renal failure. So these are the very difficult cases to know clinically. And the management. So if we'll see the management of diabetic nephropathy is a comprehensive care by the both nephrologists, physicians together, they have to manage it. And you can see this pyramid. This pyramid, this is developed by the KDIGO group. And the base of the your management, that includes exercise, nutrition, cessation of your smoking, and glycemic control, blood pressure control, lipid management. And this should be the part of each and every patient. And most patients will require RAS blockade and SGLT2 inhibitors, and some patients may require antiplatelet. I will discuss one by one. So physical activity, I think everybody knows it, and the recommendation is 150 minutes per week and moderate intensity. So what is moderate intensity? It is brisk walking, biking, yoga, swimming. And next important thing, other than the physical activity and exercise, is the nutrition. So this is a very, very big thing. Both your cause of diabetes, progression of diabetes, and diabetic kidney disease is the nutrition. You have to, unless you manage it properly, patient will develop different complications because of either lack of nutrition or overnutrition. So protein intake, then the fat intake, energy intake. Actually, energy intake, usually we see majority of the patients are probably they are advised less energy per kg. What I have seen, many of the patients are advised so less energy that they develop protein energy malnutrition or protein energy wasting. So one particular patient should have at least 30 to 35 kcal per kg per day, unless somebody is aim for a weight reduction. And sodium reduction is 1.5 to 2.3 gram per day. That means 5 grams salt. So protein, protein is known as the kidney poison. So what should be the amount of protein a patient should get? It is recommended 0.6 to 0.8 gram per kg. Weight should be given to a patient with CKD or diabetes with kidney disease. Next question is whether it is a plant protein or animal protein. Actually, a lot of recent research shows that the plant protein is better than animal protein. So plant proteins, why it is better? Because the plant proteins, the organic acid produced by your plant protein is less, and the other chemical like sodium, potassium, your phosphorus are less in case in plant proteins than the animal protein. So plant protein is better than the animal protein. And I think everybody knows that salt reduction definitely decreases cardiovascular disease, decrease risk of stroke, and decrease progress on the CKD. And it should be less than 5 grams of salt, common salt. And time immemorial, actually maybe last 60 to 70 years, the fat has become a villain. Actually, everybody's fear the fat causes heart disease, fat causes this, fat causes that. So ultimately what happened, actually we stopped giving patient fat. Any mention of any fat, everybody shivers that fat will do something. But now, suppose in case of DKD, diabetic kidney disease, we cannot give more carbohydrate because there is diabetes. We cannot give more protein because there is kidney disease. Then how patient will get the calorie? If you cannot give your carbohydrate, then how will you get calorie? So it is recommended that a diabetic DKD patient should get at least 25 to 35% of his calorie requirement. Suppose you calculated the particular patient should get your 2000 calorie per day as per its body weight, and 1/3 of that should be fat. So that means around 600 to 700 calorie from the fat. So that may be, if you will translate to 1 ml of oil is 1 ml of oil is 9 calorie. That means 60 to 70 ml oil or fat he requires. So it is my request to everybody: don't ask the patient to stop eating all fats, because particularly in a diabetic kidney disease, they require calorie which we cannot provide from carbohydrates. So you have to provide it from fat. Next question: what type of fat? So this is diabetic. The American Diabetes Association given that what type of fat. So you can give this monounsaturated nuts, like nuts like almonds, olive oil and olives, sesame seeds, peanut butter, peanut oil, corn oil, cottonseed oil, sunflower, soybeans, sunflower, walnuts, pumpkin seeds. So sorry. And omega-3 fatty acids, actually it is available. The flax seeds are flaxseed oil, tofu are available, walnuts are available. So flaxseed is a cheaper alternative. So please give your patient adequate energy through your oils and fats. This I think actually 35 years back, actually when you were a student, you used to see this type of patient, this marasmus and Kwashiorkor. So if you want to see this type of patient in adult, you have to go to the nephrology ward or dialysis unit or nephrology OPD, because this actually our patient, diabetic kidney patient, develop this type of complication because we restrict their calorie, we restrict their protein, we restrict everything. So after a few days, the patient become either protein energy malnutrition (PM) or what the newer term is the protein energy wasting, because along with the your calorie restriction, there is also wasting because of your existing kidney disease. So I request all the audience or all the physicians that please don't restrict so much of their nutrition, so that by the time they come to the nephrology ward or nephrology clinic, they should not be look like this. They should be looking like a good hemoglobin, gloom serum protein, good patient, good preserved patient, and they should not develop protein energy wasting. So next thing is that most important is the glycemic control as they are diabetic. So what should be the target HbA1c? So several factors you have to look for: the severity of the CKD, existing of your coexisting macrovascular complication, comorbidities, life expectancy, hypoglycemia, hypoglycemic awareness, and resources to manage hypoglycemia. So if these are not there, severity is less, macrovascular complication not there, comorbidity is not there, then you can aim for a your glycemic, your HbA1c target less than 6.5. But the patient is advanced CKD. There is coexisting macrovascular complication, comorbidities, and the life expectancy is less. So your target should be liberal. The HbA1c target should be liberal. It should be around 8 or less than 8. So that is the target in case of CKD, because the if you go for a very tight hypoglycemic control, then patient will develop your repeated hypoglycemic crisis, and that hypoglycemic crisis leads to a lot of complication, stroke, cardiac arrhythmia, many things can happen. So then how to choose or select anti-hyperglycemic drugs for patient with DKD or a type 2 diabetes with CKD. So first line therapy is definitely it is metformin. But if the eGFR is less than 45, we reduce the dose. If the GFR is less than 30, discontinue it, or patient is on dialysis. Similarly, the first line therapy may be SGLT2 inhibitor, but once the GFR is less than 30, don't initiate it, or if patient is on dialysis. So the other things can be selected as GLP-1 receptor, DPP-4 inhibitor, insulin, sulfonylurea, and alpha glucosidase inhibitors, and that is depend upon patient preference, comorbidities, eGFR, cost. Many things you have to see and decide, and whether patient has dialysis or not. Next important thing is the hypertension. So hypertension, if it is hypertension, definitely hypertension itself causes kidney disease, and kidney disease causes hypertension. And diabetics, most of the diabetics will have hypertension, and you have to manage it. So it depends upon whether the patient is have a proteinuria or non-proteinuric. If proteinuria is not there, then the target, if patient is 75 or less, then target blood pressure is 140 and 140 over 90. If it is more than 75, it may be 150 and 90. And if it is proteinuric, patient is proteinuric, then target should be little bit stringent. It should be less than 130/80. But above 75 years, it is the same whether it is proteinuric or non-proteinuric. And every diabetic kidney disease patient should include either SC inhibitor or ARV, and try to give the maximum dose the patient tolerates, or patient develop hyperkalemia or hypotension. And so this should be a regimen in most of the patient, unless the patient develop hyperkalemia or hypertension. So recent advances, actually a lot of drugs, number of drugs classes has been investigated within the context of CKD, but few have shown the significant clinical benefit. So last few years or decades, so many drugs has been tried. This red one, so nothing helped this kidney disease in diabetics or kidney disease in CKD. Only 3 drugs stood the test of time, that is SC inhibitor, ARV, and the newcomer is the SGLT inhibitors. And another is I will discuss the newer one. So the effect of SGLT2 inhibitors on cardiovascular, renal safety outcomes in patients with type 2 diabetes mellitus, chronic kidney disease, a systematic review and meta-analysis. So this is a big study. It included 27 meta-analysis. 27 studies included up to 7,300 patient participants, and they have included eGFR less than 30. And you can see that relative risk reduction is 0.71%. And the conclusion that SG2 inhibitor reduce the risk of cardiorenal outcomes in patients with type 2 DM and CKD without clear evidence of additional safety concern beyond those already known for the class. And the new chap on the block is Fenrinon. Just it is maybe
Sir,
last.
we are try to finish it up.
This is the last slide. This is the last slide.
Yeah.
This is a Fenrinon reducing the cardiovascular mortality and morbidity in diabetic kidney disease, Figaro DKD, and they have shown that this decreases all-cause mortality 8.5 versus 9.4, and all-cause hospitalization. So the details will be come probably maybe coming months. And my take-home message from this slide you can understand. In addition to nutrition and diet, exercise, reduce the inflammation with SGLT2 inhibitor, GLP-1 or non-MRS, RAS inhibitors, hypoglycemia. I think it is your what you will choose, but hyperglycemia to be controlled, and hemodynamics by your AC inhibitor, ARB, SGLT2 inhibitors, and non-steroidal MRS. Thanks for kind attention.